We'll make a start. So welcome everyone. Thanks for joining today, and slightly different panel today. As you can see, we've got Marion and Craig with us. I'm going to start by acknowledging the traditional custodians of the land on which we're standing and meeting in our sites, and that's the Wurundjeri people, the Burrarung people, and the Boonwurrung people of the Kulin Nation, and pay my respects to elders past, present, and emerging. As said, I've got Dr. Craig French with us today, who's the head of intensive care at Western, and Dr. Marion Kainer, the head of ID, and well known to many of us on webinars, this one and many others. So thanks both for your time today. Today I want to start, before I hand on to Craig to start with, to acknowledge what is a pretty challenging and somber day at Western Health. I am incredibly thankful and hugely impressed by the huge amount of resilience and resourcefulness that you, the staff community, have, and our senior leaders in rising to the challenge. But I do want to start by acknowledging the fact that our senior leaders, clinical staff, are making hugely challenging decisions today, and they have been for the last few days, largely deciding who gets what care. And that weighs pretty heavy on all of us, and those decisions are not taken lightly. Yeah, as I say, a huge thanks to all the staff that are doing that. We did have these plans in a cupboard, hopefully never to see the light of day, but many months ago we set them up and now we're having to bring them in. So shortly, Craig will talk about his COVID experiences and what him and his team are seeing currently. Before I do that though, I thought I'd mention mandatory vaccination and give you a bit of an update. As you know, a little while ago, the government made a legal and lawful direction to us that staff working in all of Victorian healthcare services had to be vaccinated. As such, that's been made, and that's what's happening. The first of those key deadlines is coming up shortly, and that's the 15th of October. By that date, staff either have to be vaccinated or have evidence that they are going to book an appointment to receive a first dose by the 29th of October. There are a number of staff currently listed that are unvaccinated, and that's only because we don't have the evidence of your vaccination status. So we are going to be seeking evidence from you that you've either got the first dose or may have both doses, or have got an appointment by the 29th to get that first dose. Up front, I want to be really, really clear that we, and I particularly, don't want to lose any member of staff as a result of the decision not to receive the vaccine. It's really important that I make that up, and I'm probably going to comment that this is probably one of the most important vaccines that the world has actually created and developed. Craig, I'm sure will give us some information on that later. But I want people to be assured that we are going to have to take action. If staff aren't vaccinated, we have to give you every possible protection, both for you, your colleagues, your families, and our patients. Last week, Marion, Shane, myself, and Deb Hill answered a huge number of questions, and the webinar is on the microsite if you want to go back and watch it. Today, we're on a bit of a time pressure, so we only have an hour for this session. We can't go over, and I would like to say we'll do our best to answer all the questions. I'd also like to apologise to colleagues last week who found the webinar quite confronting. I know a few people have stopped me in the corridors and said they had to leave. So I would ask that people actually keep the debate reasonable and respectful, and that we don't get into party political shaming of people or naming, because I don't think that's particularly helpful. We have got a lawful legal direction, and that's what we're applying. So I wanted to say that up front. So Craig, I'm going to hand on to you because you're one of our clinicians that are at the sharp end. There's a huge number of you and your colleagues dealing with COVID patients that are coming into our hospital now in ever increasing numbers. And I think it's really important to understand what you're seeing, what you see the differences from wave 2 to now, but also your views on vaccination and why that's important from your perspective and or an ICU perspective. So Craig, over to you, and thanks for being here today.
Yeah, thanks, Russell. So as of now, there are 104 fellow Victorians intubated and on life support in Victorian ICUs, and another 50 on top of that, not intubated, but very, very unwell in intensive care. And the overwhelming majority of them are unvaccinated. The other important factor this time compared to last year is the age of the persons we're seeing. So there are 50% of people in ICU this time are under the age of 50 years of age. And indeed, I found it very personally confronting the weekend before last when I walked into the unit and there were 10 patients with COVID there and only one was older than me. I'm 56. They're all younger than me and they are all unvaccinated. What is also very sobering to know is that if you are over the age of 40 and get COVID, you have about a 1 in 6 chance of being admitted to hospital and around a 1 in 15 chance of ending up in ICU. If you're over the age of 50 and you get COVID, you've got about a 20% chance, 1 in 5 end up in hospital, and only about, this is if not vaccinated, yes, and 1 in 10 of ending up in ICU. So we just aren't seeing people in ICU. There's been the odd 1 or 2. I'm yet to see one in ICU that's been vaccinated, a patient that's been vaccinated. There have been a couple around Melbourne, but the overwhelming majority of people are not vaccinated. And this is a tragedy. It's a tragedy for them, and it's a tragedy for their families and those that care for them and those that love them, because we know that in the overwhelming majority of cases, these people would not have been seriously ill enough to come to hospital or be admitted to intensive care. And tragically, some will die. As we speak, a man is being intubated in intensive care who's the age of 50 with COVID. He may not survive. And this is a very common occurrence, unfortunately, all around our town. I've intubated 28-year-olds with COVID. There are currently 2 children in intensive care with COVID. So this illness is extremely severe, is life-threatening, and it doesn't discriminate. It makes you very, very sick. And the only way that you can reduce your chance of being seriously ill with this illness, because we will be exposed, make no doubt, you will be exposed to this virus at some point over the next period of months. The only way to decrease your risk of becoming unwell is by being vaccinated.
Thanks, Craig.
Russell.
Yeah, that took a bit of a pause there. It's a pretty sombering picture from what you and your colleagues, both in Western and across the state, are seeing. So hopefully that helped give colleagues on the line a bit of a colour of what you're actually dealing with right now. And we'll get to questions at the end, Craig, on ICU. But I guess for me, you mentioned the difference in age between this time and wave 2. And I guess during wave 2, we're dealing with the sort of the original COVID strain, if I call that, and the British variant, and now we're dealing with Delta. So is it much more aggressive and much more nasty to patients that get this Delta than what you saw and your colleagues saw in wave 2? Are people sicker and iller and deteriorating faster?
There's more of them, is the short answer. This is wildly more infectious. Whereas you may recall last year, we used to think if you'd been in contact with someone for 15 minutes or so, you're probably going to be all right. You probably wouldn't have caught it, particularly if you're outside. Now you can have relatively brief contact with someone and catch this illness. It is just as severe. It's causing the same degree of lung damage, the same degree of organ failure, and the similar numbers of deaths to what we saw last year. But it's affecting many more people because it's wildly more infectious and much easier to catch.
Thanks, Craig. We'll come back in a sec for some questions in a little while. I just want to bring it to a bit of a close before we open to questions. And as I say, I started and you filled in beautifully, the challenges that we're under in terms of that illness level and severity. today, really, the organisation is kind of at the beginning of what is the equivalent to a mass casualty event. We are making some tough decisions, as I said earlier, about who can get care and who can't. We've got senior clinicians now coming out of theatres and going into the ED to help turn away patients who don't need to come in. They're not sick enough. We've got senior medical colleagues and surgical colleagues on the wards doing ward rounds to make sure that people that are in our beds have to stay there because they're in need of that precious resource. This is, a very different situation to where we were previously. It does feel a bit deja vu, but it feels a bit worse, to be honest. And this is the bit for me, as Craig sort of said, and as Marion has said in many of the webinars previously, that's why the vaccination is so important. We have a responsibility as employers to collect and record and hold the information about our staff. We've been asked to do that, and that's part of the direction, which is why we're asking people for that. And we're very clear that we can't have unvaccinated staff entering any of our facilities for the purposes of work after the 15th of October, unless they've booked the vaccine and are wearing a face shield and a surgical mask, as Shane told us all last week on the slide deck. But legal responsibilities aside, I don't want any of our colleagues to end up in any of our facilities, whether it be in the ICUs, as Craig's describing, whether it's in our COVID wards. It is not a great place to be, and it's particularly, very, very ill and challenging for those staff providing care to those people. So, as I say, we really need to get everybody vaccinated at Western Health to keep you all safe, to keep your own families and loved ones safe, to keep our patients, our volunteers, what limited visitors we have, and also our communities. There's been a huge lift. We've got over 90% of people now with a first dose, and we're nearing on almost 80% now. I think it's about 85% with double dosed. But, to anyone on this call, and there's a few of you, if you've not been vaccinated, reach out to people like Marion and many of the other incredible resources we have at Western Health, both on the microsite and in clinical roles, to get that information. It's really important that you do. And as I say, I'm happy now to open up to questions, but I would ask people to remain respectful in the comments that are made, but also to use the Q&A function, because it's easier to curate than the chat function because it moves rather quickly. So let's move to a couple of questions. Craig, there's been a few questions, and I know, Marion, you touched on this last week in relation to sort of adverse reactions for patients from the vaccine. Craig, do you know of anybody that's hit the ICU that's had an adverse reaction to any of the approved vaccines in Victoria?
Yes, there have been persons admitted to intensive care that have had adverse reactions to the vaccines, but there's been many more admitted to intensive care with COVID and COVID-related illnesses. The bottom line is that these vaccines have now been given to, when I last looked, I think it's 6 billion people around the world have had a dose of vaccine. So therefore, and they are the most studied vaccines virtually in history. From my perspective, the most research, I've never seen more research published on vaccines about particularly post-use surveillance and all that, of any other vaccine in history. So in terms of their safety and their efficacy, we know more about these vaccines than any other vaccines in history. 6.5 billion doses have been given around the world. So it is, from a scientific perspective, the evidence for vaccines is compelling. I recognise many people have strong beliefs and feelings around vaccinations, and they're real for them, but they are that. They are beliefs and feelings. And regrettably, they're not logical, because a logical assessment of the risk, the data is overwhelming. You are better off being vaccinated than not being vaccinated. So people's reasons for not getting vaccinated, therefore, are effectively not scientific. And indeed, I had a patient the other day come and say, we was in ICU, he was getting better, and he was asked, could he explore the reasons why he didn't get vaccinated? And he actually said, I didn't get vaccinated because I didn't want to be part of an experiment. But he came to realize he was part of an experiment. He was the experiment of not getting vaccinated. And he saw the results of that around him at the time and realized that his belief that the vaccine was somehow experimental and that he would be part of experiment clouded his view from understanding that he was actually unwittingly becoming part of a different experiment, which is what happens to you if you don't get if you get COVID and you're not vaccinated.
Thanks, Craig. And Marion, I know we support VIXIS, which is the Victorian, in effect, specialist immunisation service, which deals with adverse reactions. And we're one of the centres around Metro Melbourne that provides that service. And that's where adverse reactions get notified too. And I don't think we've actually had any notifications coming into us of very severe adverse reactions that we've actually had to support. I don't know if you've got a view on that as well as someone heavily involved in that service and across the state into that network.
So, I mean, we've had, following AstraZeneca, we've had, I believe, 2 patients who've had some blood clots, and they have done really well. They have made a really good recovery. And you may also have heard about patients, especially young adolescent males. That's where it really occurs. You can get an inflammation around the heart. There's a pericarditis, myocarditis. The vast majority get seen in the emergency department or by their GP, have an ECG, a blood test, and get sent home, or they have a 24, 48-hour stay. The very, very vast majority of those recover really, really well. This is in stark contrast of what happens with COVID disease. If you get the infection, there is so much blood clotting going on from that disease itself during the acute episode and for months afterwards. Similarly, you can get significant impact on the heart itself, heart failure, abnormal heart rhythm, having the heart rhythm go really fast or becoming really slow, heart failure, myocarditis. All of those are far, far, far more common if you get COVID disease. So for those of you who are concerned about the very rare side effects of a vaccine, you should be really worried about getting COVID disease, because they're the incidence, the likelihood of you getting these getting complications is far, 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 far higher. And the severity is much, much worse. So for example, myocarditis occurs within usually the first week of having the vaccine, if you have that as an adverse event, compared to if you have the disease, it can occur up to 6 weeks later and result in very significant heart failure and problems. There was a recent study which was just published, I believe it was in the Lancet in the last week, which showed an extraordinary impact of COVID long-term effects, the disease, on the cardiovascular system. Thank you.
Thanks, Marion. Craig, there's a question about whether or not there's any pregnant ladies in ICU with COVID.
Not at Western Health that I'm aware of. The other major centre that's looking after obstetric patients is Monash, and I'm not aware of whether there's any there. I have not. I have heard of women with COVID having babies, but I'm not aware of any women, pregnant women with COVID who required admission to ICU.
I know we have a couple of COVID positive ladies in the Joan Kirner service at the moment. And I know from reports that one of those patients, and we wish them the very best, is not particularly well at the moment, having already birthed, but has a COVID positive diagnosis. So the team in Joan Kirner are also doing a great job now that they've joined the fray in providing COVID care to our obstetric patients. And we're monitoring a fair number in the community that are in our sort of hospital in the home program because they're ill whilst pregnant and I don't think vaccinated. I'll get some other questions. What will happen to staff who decline to take the vaccine, will they not be allowed to work? Is this without pay, and will their contracts be terminated? So there's about 5 questions in one in that one. So in essence, as we said last week, there will be a process that we will go through that's spelt out in the documents that people are getting. It will be procedurally fair, but if we don't know your vaccine status as of, in effect, midnight on the 15th, then we will have to not let you come to work. You'll be stood down. You'll be stood down on pay, and then you will go through a show cause process. The outcome of that could be one of a number of things. You have a medical exemption. You don't have a medical exemption, but will get the vaccine. You don't want the vaccine and decline it. If we go to the final bit and you decline the vaccine and you can't comply with a lawful direction, then sadly, you're probably going to be terminated. I don't want that to happen, but at this point, there's not much wiggle room for us as your employer to do anything much. But you will go through a proper process that will be as per the requirements, and that will run its course. So hopefully that gives people some clarity on that, and that's also explained on the video from last week and on the microsite. There's a question about rights and civil and federal and state. In essence, we have a lawful direction. It does not matter federal views or otherwise. The state government, which is elected to set legislative acts, has now done that, and we will follow it. You have a right not to get the vaccine. That's entirely your choice. But as Craig and Marion have both said, there's some pretty strong evidence as to why you might want to get the vaccine. But we all understand that people are hesitant, and that's why we're offering as much opportunity to give information as possible. And Marion has given lots of hours to webinars and group discussions and probably one-on-one conversations, as well as of many other clinicians. And that will continue, as will primary care opportunities to have those chats as well. So please use all of those options to get the right information. There's another conspiracy view on that one. I won't comment on the Pfizer scientist one.
Can I make a just? I just saw one about rumble.com. And I was sitting here, I was reflecting the other day. I was a teenager and in the young 20s in the 1980s. And like most young lads then, I got up to a bit of mischief. But in the 1980s, what happened in the 1980s stayed in the 1980s. There was no social media, there were no mobile phones, there was no Twitter or whatever you wish to use. It's very different for our young people now, because things that happen stay, are recorded digitally and are there forever. And with the internet and with social media, we've been able to communicate as we've never been able to communicate before. And that has been used for good. But that ability to spread information is also being used by some for bad. And just because something's on the internet does not mean it is true. And regrettably, we have lots of good people out there, good, hardworking people who love and care for their families, that see things on the internet, things put there by evil people, people that are there trying to hurt you for their own pleasure. They do this to create fear in you. They do this to make you feel anxious. They do this to create doubt. They do this to create hesitancy. Why? Because it makes them feel powerful. What you need to do is stand up to these people. You need to actually say no. I am part of this community. I am a human being. I will protect my family. I will protect those around me. The only way to do that is to get vaccinated. And the only way to do that is by not allowing yourself to be influenced by people that are out there trying to harm you for their own self-interest. That is what's occurring. Make no mistake about it. That is what is occurring. And it's very easy. I sit there and I look at the comments on the in the Age comments, and people making political comments, people making all sorts of weird and wonderful comments. It's so easy to communicate now, and it's so easy for those that are trying to manipulate good, hard-working, ordinary people. You know, if ivermectin worked, it'd be great. I'd prescribe it. If vitamin C worked, great, I'd prescribe it. If hydroxychloroquine worked, great, I'd prescribe it. But it doesn't. This is the brutal reality. A cheap, simple drug would be fantastic, and I'd love to use it. But the brutal reality is that none of them work, and none of the therapies that we have are particularly effective. They reduce risk of death a bit, but the single biggest thing that reduces your risk of death is vaccination. And there's 6.5 billion reasons to get one, because 6.5 billion of your fellow human beings have elected to have one.
Thanks, Craig. And many of them are in our organisation that have also chosen to be vaccinated. So, Marion, on the vaccination theme, Greg Hunt has now, I think, as ATAGI have ruled in favour, have said that boosters are available, or a third shot, may not be called a booster, but a third dose of vaccine for immunocompromised people. That's now the case, isn't it? So
That's correct. So for severely immunocompromised persons, and so there's a specific list of those. So for example, people who've had organ transplants or chemotherapy for cancer, those people are eligible to get a third shot as soon as 2 months after the second shot. And at our hubs, you can get those shots if you fit into those groups.
Yeah, so if you qualify as per the rules from ATAGI, then you can get it through the state-run hubs, or you can get it through your GP. You go through the normal booking process, and as Marion said, there's a list, and I'm sure our clinical teams will be working with patients that fit that criteria, and that will all be good. The other thing, Marion, that keeps coming up is booster shots for staff. Is there any news on any developments on that front? I know ATAGI are debating that one, and you may have an inside scoop, but put you on the spot. Is there any news on boosters for staff?
Not yet, but it's likely to be on the agenda either this week or next week. So we should hear very shortly. And I keep on advocating and providing the evidence. I know that this is a very, very common question. I do want to reassure that the immunity, although there is waning of that immunity, the immunity against severe disease is actually still really, really good. But we want to absolutely optimize that for healthcare workers in terms of any infections, so even that you don't get a mild case of disease. Hopefully the next time I get a chance to speak with you, I'll have some answers to that. If I had 10 cents for every time I get asked that question, I'd be very rich already.
No, and as you say, ATAGI are debating it actively, and the sense is that, for staff, the runestones are saying it will be an mRNA booster shot. I think for patients that are going for their third shot that are immunosuppressed or immunocompromised, it will probably be one of the series that they've already had rather than a different one, but we'll see. But we are offering that, and we'll keep you abreast of that as soon as we have more information. Picking up the fact that we really don't have any limitations on social media in trying to get the message across to the public. We're using our microsites that's easily available to all. We've had clinicians promoting that. Kylie Fisher was on one of the Premier's press conferences promoting the need for vaccination and care. Craig may get an invite to one of those things. He's spoken very powerfully today. So watch this space. We are trying to give the public opportunity to get vaccine, and we're trying to give staff that as close to home as possible. So we're using all of our channels to try and get that message across to our public, as our government and many other agencies, to be fair. Craig, here's one for you. I know there's a plan in place and you've been at the heart of it. So if hospitals and ICU admissions continue to increase beyond the capacity of what we normally would have, what happens then, and how does the system cope? And then how do we keep, expanding, or what do we do to meet those conditions? Sorry, Craig, you're on mute.
No, I'm on mute. Yep. What we're trying to do is to obviously maintain the highest quality of intensive care we possibly can to the largest number of people we possibly can. At the moment, we are still working very well. Every person is getting that one-to-one care that we aspire to provide. If numbers continue to increase, then there may come a point in time where that model does have to change, but hopefully we will not get to that point as we continue to find staff, people that used to work in the sector, people that work operating in the operating rooms and other areas that are coming in and, helping us to look after these sickest of the very sick patients. But in terms of, as you said earlier, we do have plans, plans in place to how we would manage resources should they become exceedingly scarce. But what I can reassure people at the moment is that everyone who needs intensive care is getting intensive care, and everyone who's getting intensive care is getting a very high standard of intensive care throughout the state of Victoria, and we'll continue to provide that. The single biggest thing that can happen to make the ICU demand reduce is obviously to reduce the number of persons that I would say are at risk of needing to come to intensive care. And even when we talk about vaccination rates, there's I think it's about 3 million Victorians that are aged over the age of 40. So if we get 95% vaccination rate, it still leaves 150,000 Victorians unvaccinated. And they will come in, we all will come into contact with it, and they will come into contact with this virus, and a significant number will get it. So it doesn't take much, just some simple high school maths to work out that we're potentially facing, 10,000 plus hospital admissions and another couple of thousand ICU admissions over the coming months. That will stretch us, but we have plans in place to meet that demand. But we need to get vaccination rates very high so that all Victorians can have access to critical care, not just those with COVID, but the heart attacks, the people requiring major surgery, the trauma patients that go to RMH and the Alfred, neurosurgical patients, liver transplant patients, all those other critically ill people that need attention, that when we get severely stressed, there can often be delays in their management. And we want to avoid that as much as we can. And I just saw a thing about the vaccines. I'm looking at the Johns Hopkins site, and it's telling me that there's 6.492 billion doses of vaccine administered.
There you go. So no doubt we'll have a war of fact checking, Craig, but that one will do for me.
The Johns Hopkins site's reliable.
Pretty good.
Yeah.
Marion, there's one here about how long do you think clinical staff, whilst in effect double vaccinated, will have to keep wearing N95s and PPE in the care of patients? Is that going to be forever, or Craig's pulling a face, which might mean it's forever? But what's your thoughts? Is it months? Is it years? Is it a while?
I hope it's not going to be forever. I think it really depends a lot on the vaccination rate in our community and to see how much virus is going around. And so if we are able to get the viral transmission right down very, very low, I hope that much lower than it is right now, I hope that we'll be able to remove the N95 from all clinical areas. There may be some high risk areas where we still need to go and use those appropriately. But exactly when that will happen, I don't yet know. It really is in the hands of all of us and our community in terms of how rapidly our community gets vaccinated. That's really the crucial part of that. Yeah. And it depends on hopefully not having any other variants of concern arising. So it's a case of us getting transmission down and vaccinating everybody, as well as worldwide. We have to look at this as a global issue. We're seeing evolution in action, and every time there is an additional person who's infected, there is an opportunity for the virus to mutate. And so the only way to reduce those chances of having another mutant come out that is of concern is to really tamp down on the amount of virus that is being transmitted on a global basis. So vaccine equity is something that is important not only here in Australia, where First Nations people have much lower vaccination rates, as well as internationally. So we need to make sure that everybody who has access to vaccines, that nobody's left behind.
Thanks, Marianne. And there's also a question about vaccine. Sorry, Craig.
I just want to make, because a lot of the news has been, it's fairly glum, let's be honest. But there is some hope. I always look for a bit of optimism as well. I think we have to remain a little bit optimistic that things will get better. And so I look at the data coming out of Canada, and in particular, Southern Ontario, which Toronto's the major city in that region. And they have very high vaccination rates amongst their community. Well over 80% of everyone over the age of 12 is fully vaccinated, not partially, fully vaccinated. They still have some restrictions in place, but they are living life not too badly. I see that when I had last checked, the stadiums are now, sporting stadiums are now operating at full capacity, for example. They still have people being admitted to hospital with COVID, but the numbers are manageable. So that is what we can aspire to over, I think, in Victoria and Australia in the next couple of months. But we've done it tough, there's no doubt. With Victoria, we've been in lockdown for the best part of 18 months with a few breaks along the way. And that's difficult, it's awful, it's frustrating. I reckon it's easy for me to say that because I've got a job, but I've got plenty of friends outside of health that don't have jobs, that have lost their small businesses. So it's not minimising the impact, but there is light at the end of the tunnel if we can just. So I think if we want to consider everyone that's lost someone with COVID, anyone that's suffered COVID themselves and is still feeling the sequelae of that, people in our community that have suffered financial loss, people that have suffered psychological loss because of lockdown. As a community, we've got a responsibility to try and get out of this as soon as possible. And it's quite clear that there's only one way to do that.
Thanks, Craig. And Marianne, that leads on actually really well to another question about children getting vaccinated and what are the rules about 5-year-olds and children going back to PrEP and etc. Is there a vaccination that's been approved for children yet, or is it still under review?
It's currently under review. It is being reviewed by the Food and Drug Administration. And I believe in the first week of November, the ACIP, which is the US equivalent of ATAGI, is going to be reviewing the data for kids between the age of 5 and 11. To look at that, what's been asked for approval is the Pfizer vaccine, but at a lower dose compared to the adults. And so that data is currently under review by the Food and Drug Administration. And I assume that Pfizer will go and submit similar data to TGA.
Thanks, Marianne. There's a question in the box that is asking about staff and whether patients will be discriminated against in effect if they're not vaccinated. So no, the direction only applies to staff. The clinical teams are offering vaccination to our inpatients. If they want it, they get it. If they don't, we don't throw them out the hospital. We care for our patients and discharge them. There isn't any rules on that have come out yet. So that's what we do currently, and that's what we'll continue to do. We treat patients. That's what we're here for. Marianne, if a person has had a serious adverse event following the first dose of a vaccine, what would we advise regarding the second dose?
That adverse event should be reported to SafeVic, and a VicSys referral should be made, and they should be seen by a VicSys clinician. So we have VicSys clinic here, and there are other VicSys clinics around town. So we can work out what the best course of action is for that individual person. it's really impossible to go and give advice in this forum without knowing any of the details.
But the process, Marion, should be pretty clear. If you've had such a serious adverse reaction, then that will be recorded, it will be in, and the referral will have gone to VICSIS, and you should have been contacted about that if the individual reported that event. Craig?
And the most likely scenario is that you will be offered another vaccine. So my sister's best friend had an adverse reaction to a vaccine, a very serious adverse reaction. But they are now fully vaccinated with an alternate vaccine because they can't have one, they can have the other. So the likelihood of you being unable to have a vaccine because there is a medical contraindication to all available vaccines is incredibly low. And even if you've had, and as Karen, my sister's friend, said, yep, I was unlucky enough to get the a side effect with the vaccine, but I still don't want COVID. And gone out, even after having a very serious adverse event, has been fully vaccinated with an alternate vaccine.
Thanks, Craig. And Marion, I know you've mentioned webinars, the sort of 6 weeks between Pfizer vaccines, okay, and the Premier's pushing for everyone to get it as soon as possible and gone back to 3 weeks. Does it matter whether you get it after 3 weeks or 7 weeks? It's just a question to get both vaccines,
Okay, so first of all, it can't be 7 weeks because the TGA hasn't approved it. It's for 3 to 6 weeks. That's the normal interval at which it should be scheduled. Now, people have had other things happen in between. You can still get it afterwards, but as a routine, it shouldn't be scheduled more than 6 weeks apart. So it's 3 to 6 weeks. I suspect the Premier, like everybody else, is as keen as everybody to get the double vaccination rates up as rapidly as possible to go on to the next step on the roadmap. So that is what I suspect. There is going to be very little difference between 3 weeks and 6 weeks. I'd said I personally, if I had my time over, I would have it at the 6 week mark. That does not mean that everybody needs to go and have it. I think both are safe. Both are highly effective.
Thanks, Marion. And as you say, people just get the vaccine as soon as they can, and anywhere between those markers is fine to get it, and you get your coverage. So don't delay, I guess. Boosters have been offered in the US, and I think they're now also rolling out in the UK. If there's an opportunity to offer a booster program, yes, Western Health will do that. I know there's some clever minds beavering away thinking of research opportunities to try and influence practice, but at the moment that hasn't been approved by ATAGI or ethics, so we're still waiting. And as Marion said earlier, ATAGI have promised to come out with a ruling, I think later this month, in relation to boosters and what that will mean for Australia. As soon as we have a ruling on that and it becomes a process we can offer, yes, we will be offering boosters to staff should it be allowed. There's a follow-up question in relation to boosters. If boosters are to come out and be available, would staff have to have a booster to be considered fully vaccinated? Marion, do you want to take that one?
For that question, I think we have to wait a lot more data at the moment.
Yeah. No.
If I can mention the data from the United States, or what the recommendation was from the US government, it was to provide the option for healthcare workers to get a booster. It wasn't a recommendation that every healthcare worker had to get a booster. So I think we have to go and wait and see with regards to what is the true impact of having a booster among healthcare workers. And I have no idea what the government is going to go and do on that side. I would not make an assumption either way at the moment.
No, and as you say, Marion, we'll wait and see what ATAGI approve and government then do with that, and then we'll then follow the rules as we do all of the time. Craig or Marion, have you seen patients present to hospital that have had COVID more than once? So they've had first COVID, then they come back later with another COVID outbreak, I guess, or a COVID condition.
Yes, we had a patient who had COVID, who got one dose of vaccine, got a second dose of vaccine, and then got COVID again. Unfortunately, this was
must be
a
pretty
person
rare.
who was of very advanced age and probably didn't have a very good immune response to them. But yes, people can go and get that. And we had another patient, I believe, who had COVID disease, had 1 dose of AstraZeneca, had the second dose of AstraZeneca, and within, I believe, a week of that, got COVID and died. Remember, you take 14 days after that second dose to get that really good immune response. So it's just a really good, important reminder. If you've had your first dose of AstraZeneca, please get your second dose of AstraZeneca. It's really important to improve your vaccine efficacy. You're going from 60% up to 90%. So that's really, really, really important. So these are very, very uncommon events, but they do occur. And so my job is to pay attention even to really rare events. So
Thanks, Marion. That's helpful. Craig, there's a question. Austin, I know, I've done a series of videos recently, and someone is asking that a doctor in that quotes that if you get vaccinated, you won't end up in ICU and or die. Now, I'm not quite sure we're going to give Castayan guarantees because nothing is that certain in medicine. But I think, as you said, and you might want to restate the fact that vaccination is probably pretty important in stopping you getting there. But
well, that is correct. I mean, nothing is 100% effective. I wish we could have things that were 100% effective. But the reality is that vaccination clearly substantially reduces your risk of getting COVID, but then also more so reduces your risk of getting seriously ill with COVID, ending up in ICU with COVID, and dying of COVID. The data would appear that they're somewhere in the high 90s% effective in preventing serious illness and death from COVID disease. So it's pretty good. That's not to say that there aren't cases of persons who are doubly vaccinated that get COVID and unfortunately still do die from COVID. And so there was a thing about the chat about the global ICU data. Well, you could imagine if I think some of the data from Israel has been sort of somewhat misinterpreted at times because people are quoting, suggesting that the vaccine isn't working because there's still people in Israeli ICUs that are doubly vaccinated. Well, if you've got a very, very high percentage of your population doubly vaccinated, you're going to have a significant number of persons still end up in ICU with COVID, but it is a dramatically less number than it would be if they weren't vaccinated. And the unvaccinated are still way overrepresented as a relative. You've only got, I think in some nations, you may have 15% or 15 to 20% unvaccinated, but they're comprising 70, 80% of the ICU load, and only 20% of the ICU load are persons that are fully vaccinated, despite them being 80% of the population. And I think similarly, we're seeing this time in this way with the younger patients that we're seeing. It's not so much a reflection that this is a reflection that this is the virus is somehow attacking the younger persons selectively this time. I think it just reflects that the population over the 70 at the start of this outbreak already had a relatively high vaccination rate. So we're simply not seeing the number of persons over the age of 70 in intensive care because the overwhelming majority are vaccinated.
Thanks, Craig. And I know at the
People
moment
are saying they've been hacked. Okay, it's interesting.
There are 13, I know, patients as we stand here now in our ICUs across both Sunshine and Footscray. Most of them are at Sunshine, and I know the team at Sunshine have been incredibly busy since you went live taking COVID patients, and I think have swapped the ICU out several times in at that time. So in all those patients that you've admitted and moved around, have any of them actually been double vaccinated, or does our data follow the stuff that you were saying earlier? About
Well, we've had no patients in Western Health ICUs that are doubly vaccinated. It looks as though that the comment section's been bombed, so to speak, Zoom bombed. Yeah.
Okay.
But we've had no patients in Western Health that's been doubly vaccinated in ICU. But there have been a couple around Melbourne that I'm aware of. But they're, yeah. Oops. That's just the light in my office that goes out.
I was going to say, they've been hacked and they've turned the lights off, Craig.
Yeah, that happens all the time.
There's a question about, are we predicting another surge around mid-December? So the answer is, at the moment, yes. The Burnet model that the government is using is kind of showing a second peak towards the end of December. So I know Tash and the clinical teams are working hard to prepare for that one as well. But we're watching that modelling. I know government have got the Burnet Institute back in to do some remodelling based on what's happening at the moment and vaccination rates and things like those. Will Western Health accept full liability for damages received from the jab? So we covered this last week. There is a compensation scheme for that. Western Health are following a legal direction to make the jab a requirement of work. We're not mandating it, the government are, we're just following that process. So, please refer to last week's video call about some of the details on that scheme, should you wish. There's a question about mixing vaccines, different varieties and different brands. So, Marion, is that tried and tested?
So there have been several trials looking at that. This again is up for discussion by the Food and Drug Administration, ACIP in the United States, by the end of this month and early next month. And I believe ATAGI also will be looking at that as well. But it's looking promising in terms of the studies, but the regulatory authorities and the advisory bodies have not yet made a ruling on those.
Thanks, Marion. And there's another question here about, is there any transmission between mum to baby if mum is unvaccinated? Do we know?
So,
that might be a hard question.
no, so what, I have some data that is similar to answer that question. And that is, in the United States, they have found that there were significant number of neonates who had COVID in the past, but in more recent months, that number has decreased significantly. And they believe it's because more pregnant women were vaccinated and provided protective antibodies to their newborn to protect their newborn. And so in the United States, there's been a reduction in neonates with COVID because they believe because of vaccinated pregnant moms.
Okay, thanks, Marion. And there is a small number of Melbourne hospitals, or metro hospitals, I would say, that are now screening every patient that comes in. Royal Melbourne are doing an the rapid antigen trial in the ED. I believe Monash are doing some testing. Marion or Craig, is there any plans to do testing for all patients that get admitted to the hospital yet that you're aware of? Or is that still an active conversation?
So we're at the moment about to do a pilot of using the rapid antigen testing before the vast majority of patients admitted through our emergency department. So it is something which we are definitely exploring right at the present time with rapid antigen testing, which gives a result back, a preliminary result within 15 to 20 minutes.
But we're, and as you say, there's a pilot going on. I'm sure that'll get rolled out if successful. So that'll probably come to us soon. And I know the testing system is under some significant pressure at the moment from the, I think, nearly 80,000 tests that get done daily. So we're not going to overload that. We want to use it for our patients and stuff that we need to, but we will be looking at that rapid antigen once Royal Melbourne have done its test. There's a great question here from someone who works with refugees in the community about trying to get people in through the booking line. My strong view is please reach out directly to Lisa Smith, who I'm sure can help you get access to bookings in any one of our centres. We do offer group bookings, so we can sort that out a different way if that's going to be helpful to our refugee team that are working with that community. So please reach out to Lisa. Marion?
So this is just like, if you can make it easy for one of your friends or colleagues or somebody in your community to make a booking, please help them. We really need to get our community vaccinated as rapidly as possible. And so anything which you can do to encourage vaccination or make it easier for people to make a booking, accompany them to a booking, a walk-in booking, then that would be really helpful.
Thank you, Marion. Any concluding comments, Craig, from yourself before we close today?
Thank you, everyone, for listening. Just a couple of, yes, there is an antibody test, but it's not used frequently and has specific indications, but it isn't widely used. And there's been some comments about questions about molnupiravir, or whatever it is, the new Merck drug. Again, yes, this drug may be promising, but it always surprises me the enthusiasm that we embrace these new so-called miracle cures. The trial for that drug involved under 850 patients, about 850 persons. So we're enthusiastically embracing the opportunity potentially to have a drug that's been given to 850 people. Yet we seem to have doubt about a vaccine that's been given to 6.5 billion people.
And if I can add to that, the results from that drug are a 50% effectiveness with regards to hospitalization or severe outcomes, versus the vaccines have a much, much higher protection rate there. So you're better off getting the vaccine.
And a better safety profile.
Absolutely.
Okay, well, thanks everyone for listening. Thanks especially to Craig and Marion again. And Craig, appreciate you giving up your time and giving us some pretty powerful insights. You never know, you might get a call to go on the media with the Premier or others. So appreciate everyone listening in. Please, as I say, reach out if you've got any questions about vaccine. Use the microsite and all the information. Talk to colleagues, talk to your GP. It's really, really important that we do everything we can to protect you. As I say, I don't want to have to terminate anybody, but sadly, if that's the route we end up in, that's the action we have to take. That's the last resort, not the first. And as I started, a huge thank you to our incredible clinical team for continuing to lift to provide care to our community. It is hugely appreciated, and I know it's incredibly challenging at the moment. Thank you all. Stay safe, stay well, and all of the questions we didn't get to in the Q&As, we'll put through the process to make sure that we can answer them on the microsite. So thanks all. Stay well, stay safe.